So, good afternoon to everyone, and welcome to all of our panelists. So, we are running late, so we'll try to finish in next 30-45 minutes. And today's Teachers' Day, and I think Dr. Ramesh is here, so he will help us in all the difficult cases. And I think other teachers are sitting in audience, so they will help us to go through all these complications. So I will just start with my first case. So he is a 39-year-old man. He presented with a painless progressive jaundice from last 2 months. No comorbid condition. CT shows periambulatory growth, and there was a dilated CBD, prominent MPD, resectable disease. Side endoscopy was done. He had cholangitis, and ERCP was tried, but there was a bleeding from the tumor, so procedure abandoned. Underwent PTBD. Biopsy, well differentiated adenocarcinoma, and after the stenting is LFT and CBC, and all those are normalized. So we did the pancreaticoduodenctomy on around after 3 to 4 weeks after biliary drainage, 3 weeks after biliary drainage, and intra-op there was a tumor in the periampulary region. Hard lymph node was there in the CH, common hepatic artery region. Otherwise, procedure was uneventful, no need for any blood transfusion. MPD was around 2 mm and bile duct is 1.5 centimeter. So this is the video of the patient, and we usually take a video after doing all the surgical resection. So can't run the. So after this post-op day 1, patient was extubated, shifted to the ward, and this is on post-op day 1. Hemodynamically stable, pulse rate around 90, and both drains, we placed 2 drains because of the high risk for fistula. Both are serious, around 50 ml, and drain fluid amylase on day 1 on the both drains are 600 and around 1500. So I think I will ask, I start with this. So how my surgical colleague in this NCMC Vellore, so what do you interpret this drain fluid amylase on day 1? Do you do routinely? And if you do, then how will you interpret in this patient? What will be your take on this?
We do drain amylase on day 1. Drain amylase in day 1 values more than 5,000 is highly specific for clinically relevant or significant POPF. But here values are less than 5,000, so that can be one conclusion here.
Sir.
I would also like to know the simultaneous serum amylase that was there on the patient. Okay. Because sometimes you find that the serum amylase is also elevated at the same time. If the serum amylase is also high, and then this is high, it doesn't make much of a difference. But if the serum amylase is normal and this is high, then it would be significant. But actually, I think the studies nowadays show that the first day drain amylase is not as important as the third day drain amylase. That's what they say. We are still doing routinely first day just because we are protocol to, so that we can do some analysis later on. But they say it's the third day fluid amylase that is important. High, if it's still high, then the chance of a POPF is higher.
Okay. So we are not doing the serum amylase routinely. When the conditions are, if the patient is not doing well, in those cases we do. Otherwise, we do the only drain amylase. So post-op day 3, patient remains stable and tolerating oral diet, and drain fluid amylase now is 420 and 2,500. Otherwise, patient is stable, wound is fine. The posterior drain is slightly purulent, mostly serious, but slightly there is some purulent thing is there. So, I will go through these cases. So after that, patient remain stable, drain becomes serious, and we removed it on day 3 the one drain and the another drain on the day 7, and patient was discharged. So biopsy was well differentiated carcinoma T3N0, and no margins were R0. So this is not the usual. This is what we want from our case, that the patient should do like this. But this is not the routine. Sometimes we land up in difficult cases like this case. She is a 50-year-old lady borderline resectable pancreatic cancer, portal vein encased around 1.5 centimeter. Tumor was going along the GD up to the common hepatic artery junction. We gave neoadjuvant. After 4 cycle, there was no significant response. We continued with the thing, and after 12 cycle, there was a stable disease, slight decrease in size, but not much. And then we did the pancreaticoduodenctomy with Polter and resection. And because the tumor was involved in the CHA, we had to do the resection and anastomosis of that portion also. And post-op day 1, patient was extubated and shifted to patient was extubated. But on post-op day 2, he had suddenly has a 700 ml blood in the nasogastric tube. There is a fall in the hemoglobin. So, sir, I will ask Dr. Ramesh sir, how will approach this patient now?
I will go back. To me, this is unresectable pancreatic cancer. The artery is involved, the vein is fully encased. I wouldn't have attempted a Whipple. Even, and especially that there is no response whatsoever on after the chemotherapy. You say it is stable disease, but that means that the chemotherapy has kept it under some control, but it has not regressed actually. So some people say stable disease is a good prognosis, but even then, once the artery is involved and the vein is involved, I wouldn't have resected this patient. Vein alone, I would have gone. But artery is, especially CHA is involved, I would not resect it. But now that you have resected, you obviously have a bleed. So the first, as long as the patient's BP is stable and the creatinine is okay, the first thing that we would ask for is the CT angio.
So will you do the CT in the very early phase if there's a day 1?
No, here there's significant bleeding, so at that time I will do a CT angio.
Okay. So we'll go ahead with CT or will take the patient for OT?
No, I will take for a CT angio because our radiologists always insist on a CT angio before they will do a direct angio.
Okay. So actually also we did the CT angio for this patient, and so although in the early bleed usually we take the patient for OT directly, and because there was no bleed in the drain, only blood bleeding was in the nasogastric tube, and what we found on CT scan that there was a clot. Stomach was full of the clots, and portal vein and hepatic artery both were normal, patent. So there was no thrombosis, and then from CT room actually we shifted the patient to the OT, and intraoperatively this is the scenario. So I will ask my another surgical colleague in CMC that what will you do next? This is the intraop finding. The stomach is full of it's like distended, it's likely blood. Jejunum is it's full of clot. So what will you do?
It's likely a GJ bleed, sir. We'll do a gastrotomy and control evacuate the blood and see the site of bleeding and try to get.
Why not PJ bleed? Why are you thinking it's
the image wise it was most of the blood was in the stomach, and here also the stomach is distended and the jejunal loops which are going to the GJ are also filled with blood. And the NG had 700 ml, less likely for a PJ bleed to come up.
Ramesh sir, what is your opinion?
I would lift that stomach first without opening it and look at the PJ site. See if that jejunum is distended with blood, because GJ's bleeding is so rare, especially nowadays, because we cut it with the we do a bipolar of all the bleeders, and then we do a careful anastomosis. It's very rare for the GJ to bleed, whereas it's much more common for the PJ, especially from the cut into the pancreas, to bleed. So lift the stomach and look at the PJ anastomosis. It will be just behind, and if that is okay, if that area is not filled with blood, then I would do what he does, what he said.
So yeah, so as sir said, we saw that most of the blood was in this stomach and in the jejunum distal to the GJ. Less amount of blood was in the HJ and PJ limb. So we actually opened the stomach, and there was it was full of clot. We have removed the clot, and then we found that there was actually bleeder from the GJ side, and then that was reinforced, and nothing is coming from the PJ and HJ afferent limb of the jejunum on their side. So we just did the hemostasis and we have closed the stomach in that region. So after the second surgery, patient was extubated after 2 days, and he otherwise did well. And on post-op day 14, after the first surgery was discharged, biopsy was T3N1, although R0, and posterior margin was around 1 millimeter. So and he received chemotherapy and is now doing well, recurrence-free, almost at the 9-month post-surgery. So I will move to the third case, and this patient is similar, so I will just run through fast. So he is a 56-year-old male, periampulate carcinoma, history of choledochoduodenctomy. And we did the pancreaticoduodenctomy in this patient, and his post-op course was totally uneventful till the day 5. There was day 3 amylase was normal. We did the serum amyloid, that was also normal. And post-op day 7, he has a significant hematochezia and a bleed in the nasogastric tube. So we did the CT angio. So I will ask my radiology colleague to help us in reading this CT film. So it's day 5. So we first did this. Otherwise, patient was hemodynamically stable except tachycardia. We have not transfused till now any blood before shifting to the CT room.
So it looks like the CT angio axial sections. So in this we can see once again there is a little bit of hyperdense content within the stomach as well as the proximal jejunal loops. So looks like a bleed inside that.
So we after that we actually we didn't find any source, any extravascular or any pseudoaneurysm or any collection. So we did the DSA, and DSA was negative for both celiac and superior mesenteric artery run. And then we actually explored the patient because. So sir, what is your take? Do you want to explore this patient or do you want to continue the conservative treatment, sir? Day 5, hemodynamics is hemoglobin fall.
The question is that you had bleeding. Now, and since you had hematochezia and you had blood in the nasogastric tube, it's bleeding from somewhere into the lumen of the duct because your drains didn't show blood and even the CT scan didn't show blood outside. So somewhere it's bleeding. Now, your CT angio and your DSA are negative. So, even if you explore, all you're going to see is the stomach full of blood, jejunum full of blood. So how are you going to locate the bleeder? I don't know. When they did the DSA, see what happens is when you bleed, your vessels constrict. So one of the techniques is to do the DSA and give a vasodilator like papaverine into the artery, so that any constricted artery will open up and then the bleeding will be seen. Did they give papaverine and try?
No, they didn't. Actually, they do sometimes when there is any vascular irregularity in the GDA area, IPDA area, but they say there was no collection and vessels looks very normal, so they didn't.
No, but unless they give papaverine, they will not see a small bleeder, which would have closed off and then will bleed again. So some of the people would give a papaverine and just wait and then do an angio again. Now the vessels are dilated, the bleeder might have opened up.
No, I just wanted to point out that even the IV octreotide will cause vasoconstriction. Most patients in the ward, as soon as they bleed, the resident will put them on IV octreotide and tranexamic acid and whatnot. It is always prudent to stop the octreotide when you shift the patient to the radiology suite. Second is, if you don't find anything, you have to cannulate each vessel separately and then inject, only then sometimes you will find it. Even if you don't find it, it is far better, papaverine or no papaverine, still repeat the study after 6 hours, unless you are driven to that desperate situation where the patient is dying. I would not want to take the patient to the operating theatre in RE, because as Ramesh said, the yield is not very gratifying.
So I agree with sir. The only in this patient, the only good thing is the patient had no pancreatic fistula, and his abdomen was his wound is fine, and drain was not showing any bleed. So, so if you go by the ISGPS classification, it's late bleeding because it's day 5, not within 24 hours. But I think that the ISGPS classification, they are very restricted. For the late bleeding, I think we have to divide into 2 groups. One group with leak and other is without leak, because without leak patient, there might be a chance that we can do surgery, especially if we are not getting anything on CT, angio and DSA. So that's what our thought process, sir.
But I do see on this image, it's either following the CT angio or following the direct angio, that some of the bowel loops are now showing contrast. It is not just in the wall, but inside the loop also you see contrast. So somewhere something is bleeding. It has been missed, or it has already bled and that has been missed, because inside the bowel also you see some clots which are showing some dye. So I don't know. So maybe you're right in exploring the patient.
Thank you. So we actually explored the patient, and this time the both were full of the clot, and this was the jejunal limb between the PJ and EHJ. So we actually marked the thing and we opened the jejunum at this point, and we have actually, this is video taken after the removal of the clot, and we found the bleeding from the actually PJ anastomosis, and we actually reinforced the suture in those area, and after that, so patient was extubated on the second of day 1 after second surgery. However, his post-op course was difficult and hysterotomy, and he had now the pancreatic fistula by leak. We did the biliary diversion by PDVD, and we were able to discharge patient only after almost day 24 after the first surgery, with drain in situ without draining around 50 to 100 ml bile. And however, again patient admitted within 4 or 5 days with shock, although there was no, we didn't find any source of bleeding, and then we managed conservative and discharge the patient, and biopsy report of PT2 and 0. Now patient is almost a 2-month post surgery and is doing well. We are not giving any adjustments.
So this is where my technique would have helped you to avoid all these complications. I would have undone that PJ, I would have exteriorized the pancreas and closed the jejunum. Your bile leak wouldn't have mattered, recovery would have been fast, there would be no readmission with shock, the patient would have recovered. So you see that we have gone through this stage of trying to do all these repairs and failed. That is why we have now come to this exteriorization, and it's a very good procedure. The next time you have tried that, and you will find that the patient is a very smooth post-op output, and then he just comes out.
Okay, thank you, sir. So I'm not going to the literature because we have multiple talks on the post-operative complication in the post-lung session.
Early post-op bleeding, every surgeon would say immediate surgical intervention.
Yes, sir.
I think you have left a vessel or something slipped, so you would go in.
Yes.
Yes. But early is up to 48 hours. You would immediately go in, no CT, no angio, just open up.
Yes. So, every one of us actually wants this type of drain in the post-op period, and this is, but we get all type of things, and sometimes like this one. So I will not go into detail of the ISGPS classification. We will see in the post-lung session. So I will move to the another case. He is a 45-year-old male having a periembolic tumor, and found to have periembolic polyp there, and this patient underwent the Whipple's procedure, and in the May, duct was around 1.5 millimeters, soft pancreas, EHJ 2 centimeter. So this is the post-op course of this patient.
It's an ampullary tumor.
Yeah, it's a periembolic tumor.
Why did you do a triangle operation?
Okay, sir, we are doing this study in the triangle clearance in resectable periam. And we have just completed the number. We'll see the part of the trial.
But I'm not too sure that it's a good operation for, I mean, routinely those nodes are cleared, but yeah. I don't know whether it's actually a good to expose the SMA and the celiac axis for a periampullary. To the right of the celiac axis, lymphadenectomy is acceptable. But going behind the celiac axis, exposing it on the SMA, exposing it, I don't know if it's a good operation for a periampulary.
Okay, sir. So post-op day 1, the amylase was in a range of 3,000 and 10,000. There were 2 drains, and post-op day 3 amylase was also high. So at this moment, I think we can discuss about pancreatic fistula management in the post-op role of. Already, I think sir has covered in the previous talk about the role of various method. So octreotide and all those things we can try in this group of patient. And this patient has, although post-op day 7, amylase has decreased, initially improved, and it has a persistent high NG output, and then there was an increasing count. So although fever was not there, but count was in the range of 20 to 25,000. So do you want to do any investigation at this time? Although patient is not throwing fever, but having a high NG output, having a high TLC count. TLC.
Yes, sir. I will consider imaging for this patient. DG may be secondary to a leak.
So what type of imaging
collection.
you ask for? Yeah.
We'll ask for in our institute we are doing MRI, sir.
MRI.
MRI.
Okay.
Post-operative collections. CECT also will be sufficient, sir.
So sir, what is your opinion? MRI or CT?
No, CECT.
CT.
They are doing routinely, I don't know.
So,
45 minutes to do?
no, sir, the MRI, if there is collection, evidence of infections can be picked up with diffusion restriction. And it's serous collection or infected collections can be identified better with MRI. That is one reason. And there is no contrast. We are doing only a T2 MRI. So,
Post-operatively take 45 minutes to do the scan in the acute situation.
MRCP is mainly. It's much cheaper also, cost factor.
Okay. Sir.
You mean MR is cheaper than CT?
MRCP is cheaper than CT here.
No, but MRCP is not done without an MRI. So, because MRCP is only the reconstruction, so you have to do the MRI cuts to reconstruct. So, how does it become cheaper than a CECT? I mean, in my institution, MRI, MRCP is 15,000 rupees, CT scan is 7,500 rupees. But even with a contrast, our CT is only 7,500. So it's much cheaper to work. And I think in the post-operative period, you're not just looking for these corrections. It also gives you idea of your vasculature, whether a pseudoaneurysm is present or not, will also be shown if you do a CECT. So I would do a CECT because before ruling it out as a delayed gastric emptying, I want to be sure that there's no collection, because that is the commonest cause of delayed gastric emptying.
Yeah, so our also preference is CT scan, and I think very few centers are doing the MRI. So we actually did the CT scan. So I will ask Dr. Santosh to read the CT for us. So the reason was CT was persistent high count as well as high nasogastric output.
So it's axial section of the CCT abdomen. You can see some collection along the inferior surface of liver and along the caudate lobe. It's not very huge collection, but a collection is there.
Okay. And vessels, artery and vein. Okay, so this collection are there. So will you able to drain this collection? And I will just run the thing.
It's located deep in. It's not that easy, but whether we can try a trans-hepatic approach. It's possible. It's challenging.
So our radiologists also said the same thing is difficult to drain. They have to do that either trans-hepatic by route. And so I will ask gastroenterology. Will you able to help?
Yeah, I do have a window from EUS. The transgastrically I can drain it. And if you are worried about me introducing an infection by crossing the stomach and going into an intra-abdominal collection, I can always offer you a nasocystic drain tube. I mean, place that catheter in the collection and bring the external drain out of the nose. So it's easy for irrigation purpose and look for drain holes.
I think we will not like nasocystic tube in this collection? Because
otherwise there are only two options for you. I can put a metal stent or I can put a plastic stent. With the plastic stent, there is always a risk of block.
So you will put the stent tip in the collection and
one pigtail will be in the collection, one pigtail at the other end will be in the stomach. I can put 2 or 3 stents. Okay. The rate of blockage is less. We have done that. And here also I think the window is there.
So I have no experience. Any other faculty senior had any experience? Yeah, sir.
No, would you do that for immediate post-op? Is day 5?
I'm always worried about me introducing an infection. That's why I said, like, I can bring out.
I'm more worried that you may disrupt my anastomosis. So we would not ever think of...
Unless otherwise my surgeon asks, I would not touch. Yeah. If you have no other option, only if you are coming as the last resort, yeah, I'm there.
I have a further clarification. So we have a day 5, day 7, day 9, like post-operative collections. And essentially what you are doing is you are saying you will drain it into the GI tract. Is that not true?
Drain into what?
Into the GI tract.
Yes, sir.
So I thought for GI tract draining, even in a WON, we wait for complete sealing of the collection,
yes,
which is very unlikely to have happened here. And I don't know if I would allow anybody to go through the bowel wall and disrupt the bowel wall at this time. You can inject, you can do a needle and aspirate. That may be acceptable, but if you are going to put a nasocystic catheter, God, I would not support it, simply because the collection itself would be very tenuous. It would not have localized walls, and it would be run the risk of not only disrupting the anastomosis but creating new issues.
I'm not draining a cyst here, sir. It's about infection. If it's infected, we have to drain it.
No, it's a collection.
It's a collection. Only when you're asking for drain, if it's indicated.
If it is not well localized, that's the point.
Source control of infection, sir. That's only indication. If they're asking for source control of infection, we do it.
More.
It's here that actually our MRI comes into play. If there's diffusion restriction, then we know it's infected and we should treat it. Otherwise, we would just give antibiotic and wait.
But very likely it will be infected, sir. The only thing is putting the drain. I think most transgastric stent will be very uncomfortable because there is no wall. Aspiration only. Maybe.
I don't think whether it's infected or not. This is a pancreatic fistula.
Yeah.
Which is now not draining out. It's inside because the amylases were so high. And though they have come down, they have not come down to normal, they are still 2,500. So I am worried that there is a leak from the PJ. And with a leak from the PJ, putting a drain is an option. If they can put it percutaneously, I would be very happy. But somehow going with a EUS scope, putting carbon dioxide inside, dilating the stomach, now you are opening yourself to a GJ leak if on the 5th day when the sutures are going to give way. So I would be a little hesitant.
Yes, sir. So we actually follow the same and we continue the conservative. You want to say something? Yeah?
It's about the timing only. Recently also we had a leak. On my surgeon and we just put a nasojejunal tube. We were waiting for 6 weeks. We didn't touch the collection or we didn't touch the PJ leak. As I said, you asked me whether the window is approachable. Yes, approachable. Depends on what you want, because I wouldn't want to contaminate by my scope. A single time aspiration also we will be very, very careful. Okay. I'm still introducing an infection. Okay. Unless whether you're desperate or not, that's what matters.
Okay, so your point's taken, so we will move slightly fast. Almost after 1 week, patient is still having a persistent fever. It's persistent high count with low grade fever now and having high NG output. So this is a repeat CT. So I will ask my radiology colleague, can you read the CT for us?
So it looks like the interval CT shows increase in the collection along the caudate lobe and the inferior surface of liver. But this time it might be approachable between the vertebral body and the stomach, between the vertebral body and the liver. I think we have a window, we can drain that.
Yeah, so we drained the collection and around 700 ml initially purulent and it's a pancreatic leak fluid was there. He improved a little bit, but again he developed a fall in the hemoglobin. So this is the CT of the patient. Although there was no bleed in the drain and pigtail both, but there was a fall in the hemoglobin. So we did the CT angio this time because of the large collection was there for a long time. So we thought there might be some thing. radio. Please.
So actually there's a difference between the collection which was previously and now. You can see an hyperdense content within the collection. That means there's a fresh bleed in that collection area. And there you can see a small outbulging at the GDA stump. Yeah, that's the one. So it looks like a GDA pseudoaneurysm there.
So yeah, so we did the DSA, and this is a DSA image. So there was a GDA bleed, and our radiologists felt that they are not able to do the glue embolization, and they did the stenting of the common hepatic artery. Yeah, it's a covered stent, sir. It's a short covered stent. Yeah, this is the stent. So that was done, and after that, patient has improved. Hemoglobin is stable. Drain has been removed on day 31, and he has been discharged on day 33. And I will move to the last case now, because of yeah. So this is a 70-year-old man who has been diagnosed incidentally a pancreatic head lesion, query serous, query calcified cyst. So he was on regular surveillance for 3 years when he developed jaundice and cholangitis. Patient was stented, and now there was doubt it might be neuroendocrine tumor because of the arterial enhancement. Chromogranin was borderline, and Totanoc was actually in favor of neuroendocrine tumor. So we did the pancreas Whipple in this patient, and there was a mass in the head, and the large retropancreatic lymph node are there. So and pancreas MPD was 3 mm. His post-op period was uneventful. There was drain fluid amylase were normal. However, it is a persistent high nasogastric output. So on day 7 to 11 is in a range of around 500 to 1100. He was otherwise tolerating the feeding genostomy well. So what next, sir? So it's almost second week.
So in this situation, what I have found is that once you crossed to 11 days, now the sutures have healed. So I would do an upper GI endoscopy. See, this is obviously a delayed gastric emptying. So what I want to know is the anastomotic edematous, whether I can enter both the loops, afferent and deferent loops. Sometimes the very procedure of entering the afferent and deferent loops opens the anastomosis, and then the DG disappears and the patient starts passing. So that's what I would do first.
So I will ask gastro people, what is your approach for when you do the endoscopy in this patient having delayed gastric emptying? So any special precaution, anything you will do during endoscopy?
No, prior we aspirate and then we use minimal CO2 insufflation, and we always have the surgeon by the side. By the assumption, I mean there is a prior imaging which is...
Sir, please.
Perhaps I should be answering that question because I am a surgeon who does my own endoscopy.
Yes, sir.
So I will let no medical gastroenterologist near this patient. I will do the endoscopy. Yes, the first thing is you set the insufflation at low level. Second, all our endoscopies are done with carbon dioxide. So if those who are doing it with air, don't kindly do this endoscopy because the air stays for a long time. With carbon dioxide, it tends to get absorbed. So I will do it at a low pressure of insufflation, and I will straight away go on to look for the anastomosis and do and enter both loops. Sometimes you can't enter. What you do is under a C-arm, you pass a guide wire into each loop. And then over the guide wire, you can then guide your scope into each loop. And sometimes that opens the anastomosis and it becomes all right.
Yes, sir. So, sir, I will ask Dr. Gilbert and Dr. Achilles. So, do you want to do CT scan before that?
Yeah, we would like to know if there's any other evidence of an infection, like the raised count.
Although clinically patient is not in sepsis.
But we had to rule out secondary DG. So, cross-sectional imaging with the CT scan is still recommended at this point of time.
Yeah, so we did the CT scan, and CT scan. So Dr. Santosh, what is your? Please read the CT for us. Sorry, I put on fast. So Okay, so we are running late. So it's CT, so there is no evidence of any collection. The stomach was hugely distended with the contrast. And it's, even after the delay, we did the X-ray, we showed the contrast is still in the stomach. NG output was in this range throughout. And upper GI endoscopy showed there is a residue in the stomach. Both limbs were normal. We did still almost 6 weeks post-op. Patient is having significant NG. So we are doing the intermittent clamping also, but he's again discomfort and sometimes vomiting also. So we actually did the emptying, this colloid scan that was around more than it's abnormal. And so what next, sir? So almost 6 weeks post-Whipple DG. The biopsy was neuroendocrine tumor, grade 2.
I think you need to reoperate. You need to resect a little bit more of the stomach and redo the GJ. So that is the only way to now salvage, because after 6 weeks, it's not going to settle on its own. You've already done the endoscopic procedure, the loops are open. So it's not an anastomotic problem, it's a stomach problem. So you have to now, so you want to resect a little bit more of the stomach. So first question I would like to know is, what did you do? Did you do a pylorus preserving or a pylorus resecting?
Pylorus resecting, sir.
Pylorus resecting. So I think another 2 inches or 5 centimeters of stomach can be resected and a GJ can be done.
Any other opinion?
But we have particularly not seen patients whom we had to go back and reoperate only for DGE. We had patients who had prolonged DGE 2-3 weeks, but they had eventually settled. And in 6 weeks, we have not particularly. I think the only option.
Will your partial resection work? I thought the recommendation would be a total gastrectomy.
No, not a total gastrectomy. I think that would be too much for this patient. I would do a partial resection, and I think
because I'm going to ask you the same question. Doctor, will I be well after your partial resection?
Well, I have never had to do this. I am just giving a theoretical answer, because I have never had a DG which required to be reoperated.
So anyone else has any personal experience of?
We have sat on a patient like this. He's a diabetic. So nearly 2 months. We had a feeding judge, so we were very relaxed about it. But we have seen that sometimes the feeding judge contributes to this, and just stop the feeding judge, give 48 hours of rest, and sometimes they just start working for no reason. Because I've seen this feeding judge contributing to this.
I don't know whether the feeding judge contributes, but actually my answer was theoretical, because I have never practically done this ever in my life.
So we have looked.
I would like to ask, have you reoperated for a DG, Ramesh?
Not yet.
Have you operated, Rabella, for a DG? So some of the most experienced pancreatic surgeons, Philip has not operated, I have not operated, Rachel Mesh has not operated, Rabella. So this is something that we have not come across. So we don't know what is the reason. I'm sure you have tried everything, given metoclopramide, erythromycin, you have given all those drugs and nothing has worked.
Even he bought erythromycin from US.
So it's not worked. So then I am worried. I never thought of this problem. What Philip is saying is quite correct. The DG may not settle with a partial gastric resection. You may have to end up with a total gastrectomy, which would definitely make sure that there is no problem. So that is something that you have to think of. And because I never thought of it when I gave the answer, because as I said, no practical experience. So
I think waiting and watching would be the best bet. I agree with Philip that do you know the German surgeons and the Swiss surgeons do not do feeding jejunostomies and do not give nasojejunal feeding either, because they believe the intestinal break is initiated and that delays gastric emptying. There are several papers that they have published. And they are very much against our policy of giving enteral feeds early. But for us, it's a life and death situation, so we have to give it. A small segment of patients who have this problem, I would certainly go with Philip and say, give them a 48-hour, 72-hour intravenous fluid regimen, and it often gets them across the line. I would support that.
Thank you, sir.
Yeah, well, I think I agree with Philip that we never go in again, and we had few patients who had gone beyond 6 weeks also, and they settled down. And the intestinal break, what Ramesh is telling is true. In the last a couple of years, actually, we spaced between the oral diet and the diet through FJ, and less fat in the FJ, and addition of some, I would say, partial parenteral nutrition. And we found that actually the DG settled quickly. I don't know for whatever reason.
So you will stop the feeding jejunostomy and give the TPN?
No, we give bulk, but we space it much these things, and then less fat in the feeding jejunostomy, okay. And some of the calories if not able to met partial parenteral, and they settle down quickly.
That's one.
I don't know whether how it worked, but it did work in the last couple of years. We have been shifted to that, okay. And probably what Philip's saying is okay. Take it off for 2 days also might be true.
Yeah, as you delay the feeding and feeding jejunostomy, there will be a lot of bile secretion. That will cause bile gastritis. That will delay the cause of the gastric empty. Already, of course, I will stop the feeding jejunostomy, aspirate the bile, and give saline wash also 4 or 5 times daily. It will settle. Bile gas is the biggest problem. Lime juice will... No reoperation. It's mainly the bile gastritis.
Yeah. So actually we reviewed the literature, and so most consistent result was given by the almost total gastrectomy, near total gastrectomy, and partial gastrectomy has not was equivocal outcome. We offered the patient for surgery, but fortunately a patient is not willing for surgery, so we kept the patient on follow-up only. And almost after 3 months, almost he settled, and now he's almost 2 years post-op.
As you delay the feeding, there will be nothing to dilute the bile also.
One of the things that you can think of, if the jejunum is not coming, because you've already taken the easiest loops to the thing, and the loops may not be reaching the after total gastrectomy. Remember that you have an option. Prepare the colon and take a segment of the transverse colon between the esophagus and the jejunum as a conduit. Once I had a total gastrectomy, and this ended up as an esophagogastrectomy in the chest because the margin was positive for tumor, so I had to take 5 centimeters more of the esophagus. So I had to open the chest and and the jejunum had a short mesentery, won't reach. So I scratched my head. I had not prepared the colon, but I saw that it was a long transverse colon. So I just, with a vascular supply, I disconnected it and took it and did an anastomosis to the esophagus and to the jejunum, and then colocolic anastomosis, and the patient did wonderfully well. Absolutely, just like esophagojejunostomy. No leak, eating on the 10th day, no problems, and he lived for many years later before dying of an MI. So colon is also an alternative that is there. Remember that. It's not always has to be the jejunum.
Okay. Thank you, sir. I think we are already running late. Any comments from any panelists? Okay. So we will just summarize the thing that you have to, the clinical judgment and the prompt CT is very important for these complications, and immediate surgical intervention in early post-op bleeding is the key, and we should do that if the bleeding is within 48 hours said by our panelists. And sentinel bleed, you have to be try to identify and take care by the either angio or embolization, and sometimes you have to do surgery also in those cases. Sir.
Early bleeds, re-explore. But late bleeds, stop it by angio or by surgery. But remember, late bleeds are invariably associated with a leak. You have to deal with the leak also. Don't forget to deal with the leak.
Thank you, sir, and thank you all the panelists and all the audience. Thank you.